Okay. So we have a brand new concept in drilling, and I think is going to literally reshape the way we look at bone and how we're going to treat bone. So this is the first time we're giving this course. We've had some brief introductions to some of the drills that you'll see that we're going to be using today in some previous lectures on stage, and we had some history with it. These drills are a couple of years in the making, and we're going to introduce to you this new concept. We're going to bring it to you here at Dental XP, which is where the first time this drill was ever mentioned was at a Dental XP event. So it's great. We're breaking out of this pandemic, and we're back, and we're here, and able to be in live courses again. And so we felt this was the time to start to bring it back and to introduce it and to really push it, to show you guys what we've been doing over the past few years, how we've been avoiding lots of complications and simplifying our cases dramatically. So for those of you who don't know me, this is a list of who I am. It's not actually who I am. It's just a list of things that I do. There's a lot of different events that I've been with over the years, lots of different companies that I've worked with over the years, and as a disclosure, I am a partner in TBS Dental Instruments and also Universal Shapers, which is the concept that we're bringing to you today and the drill kit that we'll be using today. My other partner is Dr. Gary Brown, as a disclosure as well. So we're going to introduce you that. You can see over the years I've been KOL on many different products. We brought a lot of new products to life, and they're in existence, functioning extremely well, and people are benefiting tremendously from those, like Densiburs, for example, or Dentin Grinder, or many other products over the years that I was an early adopter of. Some techniques like socket shielding, partial extraction therapy. I have cases that are now over 10 years old, almost 11, 12 years old. So we've been advocating these types of techniques, pushing the envelope, and here I think we broke the mold, literally, and reshaped what we consider an actual osteotomy for implant placement. So you can see there that's the disclaimer for the financial disclosure. I am not getting paid honorarium from myself as a partner here, but I'm here to introduce to you this concept. So most of us have experienced recession over the years. We have placed an implant. We have a simple solution to do that. We create an osteotomy. We allow it to heal. We put an abutment. We put a crown. And then over time, from day one when we insert the abutment, something keeps happening. Something biologically keeps occurring. And we may see some recession, some bone loss, some gingival recession, and that may lead to some aesthetic failures. It may lead to some peri-implantitis. I'm not telling you anything you don't know. But for years, we were having this scenario which we like to term affectionately dieback. I don't know why we came up with this name dieback. The bone dies back. That's bone loss. It's not dieback, it's bone loss. So to me, dieback is equal to bone loss. We end up with these scenarios where we lose bone around the neck of the implant, it shrinks back, and we have a crater defect. And then we have to do a surgery. Sometimes we have to remove the implant. Sometimes we can try to preserve the implant, de-thread it. If it's not too bad, keep it, maybe put some bone graft or some soft tissue graft around it, and try to not repair, we call it revision surgeries. Why? Because nothing's a failure, right? Nothing's ever a failure. Everything is a revision. If it didn't work the first time, we're revising it. We're changing the plan. So the word failure has kind of been eliminated over the years, more and more from the actual vernacular in implant dentistry. And we use these affectionate terms, dieback, revision surgery. And this is what's been happening over the last several decades. But why are we getting this dieback? Some of you may know the answer, some of you may not, but let's discuss some of the details of what occurs with it. We have three typical type of scenarios that present to us when we are dealing with bone. We get these wide, thick ridges that literally anybody can place an implant into. May have good soft tissue. Usually when there's good bone, there's good soft tissue. And then we have scenarios where the bone's just a little bit thinner. And this is the most common scenario that presents to our office. We get a thin ridge that's not too thin. It's enough to place an implant, but it may not be the implant size that we're trying to fit in there. We may have to compromise and choose a more narrow implant, or we have to augment either with hard and soft tissue or separately. So that's the most common one. Then we have the thin ridges. And for those, we know what we have to do. There's really no magic. There's different techniques. We'll go over a couple today that we can treat for those. But in general, there's not much we can do just placing implants same day, unless we're trying to do, let's say, a ridge splitting type of scenario where we put the implants in simultaneously. But there are some risk factors with that. Those of you who have taken my ridge split course over the years, which was always offered at XP for many years, will know that I usually like to place my implants the same time that I do the ridge splitting procedure. But that's a more complex. What's most common and what presents to us typically on a daily basis is these cases where we have about 7 to 8 millimeters of ridge width. So basically, we have to look at the bone, try to prepare the bone, and preserve the peri-implant tissues that support it, and not try to put ourselves in a situation where we start to violate some of the rules. You may know some of the rules, like from Spray, Nozawa, Etimoto, Grunder, did also studies, but we basically need about 2 millimeters minimum on the facial plate surrounding the implant. We cheat on the lingual or the palatal side, but we never really like to cheat on the buccal portion. And when we cheat too much, because who can be so perfect with a 7-8 millimeter ridge, placing a 4.5 or 5 millimeter implant to get 2 millimeters on one side and 1 millimeter on the other, maybe by the use of guided surgery, dynamic navigation, maybe we can accomplish that. But in a free-handed environment, this often presents to be quite challenging, and often during surgeries, we're constantly augmenting to try to recreate or rebuild to get ourselves into that ideal position. So we need to look these days at implants that can accommodate for these 7 to 8 millimeter type width bone cases. So we look for implants that are more cut back. We look for abutments that have platform switching, which we'll discuss in more detail. We'll look for the image on the right side or your left side of the screen for an implant that looks much more similar to this with a cut back design versus an implant that has less of a tapered design at the crest. So we'll try to pick those. Why? Because it gives us a way to cheat. By having the thread start a little bit lower down, we can cheat and now have a narrower neck at the top and have more bone for us to place the implant, which is great. And for the implant like we're using today, we're going to use one from Megagen, the AnyRidge. This is one of the pioneers. This is over 10 years I've been using this implant. It's one of the pioneers in that respect of this cut back design where the threads start a little bit more lower down. So we can see these little widths over here of bone. We can preserve more. We can have a little bit extra soft tissue and extra bone to accommodate, whereas the implant on the other side makes it a little bit harder or more challenging in those situations. In the wider situations, they work perfectly. But in the more narrower situations, that's where we have to start choosing a little bit more of the type of an implant that can accommodate that bone, or we have to augment. It's just that simple. And there's nothing wrong with using either implant. They both work. You just have to know how to use them and how to be able to accommodate for the scenarios that you may be faced with. So these different designs are important, but also the depth of where we place the implant is extremely important. Certain implants need to be placed at bone level, others subcrestal. How much subcrestal varies from implant company to implant company, often dependent upon the type of connection. And these more conical design implants can be placed a little bit deeper. But let's say we take a threaded implant and we place it at the bone level. We have a choice. We can place it at the bone level, or we can take a thread implant with less of a thread design where it starts lower down, it starts a little bit higher up. And you can see this one here starts a little bit higher up. And now we don't have as much bone preservation. So no bone preservation here. We already have exposure because of the lack of taper design. Here, the thread pattern starts a little bit higher up, so we lose a little bit more preservation of bone. Or we can get an implant that starts with the thread pattern a little bit further down to preserve this area of bone, that crestal bone width, that all-important crestal bone width, so that we don't end up having the dieback. But yet we still seem to have dieback even when we tried to accomplish this. And we never call, I love the definition of success. They say an implant is 95% successful. What's the word successful? It's still in the mouth. It has bone loss, threads, aesthetic nightmare, but it's still in the mouth. It's hanging around. That's success. So that definition of success is not truly what we would say 95%. It's probably more in the neighborhood of 80% of implants are ideal in the patient's mouth, and maybe even lower in some parts of the world. So looking at these over time, we'll get more bone loss when we place it at the crest with less bone. An implant like that, again, the threads will start to get exposed. Once those threads are exposed, you know you have a nightmare on your hand. You have to start dethreading and augmenting. Whereas another scenario where you get the dieback, the threads are not exposed yet. And we may get some type of a long junctional attachment that may form around it, or what we like to call a COL, C-O-L, effect around the implant. So this is kind of what we expect with these type of implant designs. I am not including tissue-level implants here. That is out the window for this conversation. Tissue-level implants is a whole different ball game. And they work great. They work great for the posterior. Sometimes in the anterior, we try to avoid those because it's sometimes very difficult if we need to do something later on, a revision surgery, basically, to recover. So bone level is nice because we can keep switching out the platform and not have to worry about where that margin of tissue level is. But tissue-level implants, different breed. So we're strictly talking about bone-level implants for this. And again, that stable dimension from all of these different studies over the years is pretty much that we need a good amount of soft tissue. We need a solid facial plate of bone, at least 2 millimeters. The word at least, right? We never like to do the bare minimum. The bare minimum is I got a 70 on my test and I passed college. The better way to do it is to be the valedictorian and have that wonderful grade, 4.0 average, and you're graduating with a wonderful degree and a great history. So we want more than 2 millimeters. We want 3. We want 4. We like more. So we want to try to use designs to try to help us preserve more of that bone to give us that little leg up advantage. And Dave Garber, I don't think David is here this weekend, but you know him from Team Atlanta very well. He works with Dr. Salama and the rest of the team in Atlanta, with Dr. Goldstein. And he came up with this, coined the phrase, the bone sets the tone, the tissue is the issue. We realize that. We need bone. The tissue has always been the problem. And over the years, we've had so many courses about soft tissue. As a matter of fact, some of you may be taking the course later today with Ihab and Dr. Salama, Dr. Musa and Dr. Salama for the soft tissue grafting. It's paramount that we learn soft tissue surgeries. Nothing's going to replace that. Even what we're going to teach you today, you still need to know soft tissue grafting. You still need to know how to augment because there's always going to be scenarios where we're going to need that. But what we're going to show you today is to try to reduce those scenarios and keep them at a very minimal number. So this is a formula that you can use to predict what's going to happen for bone loss. We know that the body needs to have more width of gingiva than it does vertical component. And there's a formula that it's going to be 1 to 1.5. And that makes perfect sense, because if we have a larger vertical component, that means we have very, very long periodontal defects, right? We have a probing depth of 4 millimeters, 5 millimeters, we start to get a little bit concerned. 2 millimeters, we're feeling great. I don't know how many of you probe implants. I don't love to probe implants. I'd rather not. I'd rather not create issues if I don't have to. But light probing around to see some blanching, certainly nothing wrong with that, so we do that. But we don't try to push all the way down to the ground. We're trying to take a light approach to it, and we can monitor that. We don't like to see bleeding. With 4 to 5 millimeter pockets, if you probe, you're going to see bleeding. It's natural. It's just the way that it's going to work. So this formula of the volume to height, vertical to the horizontal component is important for us. The body wants to level it out, and it's going to resorb until it reaches that level, if you're lucky. If it doesn't, it's going to do the opposite and create a very, very deep pocket, and you're going to have food caught in there, a piece of popcorn is going to get in there, it's going to be a nightmare, and then we're going to have to do a revision surgery. So this book and this topic, the zero bone loss concept by Dr. Linkiewicz, has been all the rage. I think it's number 1 or number 2 popular selling bone in Quintessence. I think Rick Myron might have passed him this year. but he has an online course. It's wonderful. He's really, really well published. He has many articles about the zero bone loss concept. And that's a great thing to hear, the word zero bone loss. I wish that every single case that comes into your office will have zero bone loss. But the reality is you're going to have some. But why is he getting zero bone loss? Or if we say minimal bone loss. So we'll discuss some of the reasons as to why Dr. Linkevich is getting those type of responses. Is it because he's doing soft tissue grafting on every case? Is it because he's putting bone in every case? Or is he respecting some of the rules of biology? That if the tissue thickness is less than 2 millimeters or less, we're going to have bone loss up to 1.4, 1.5 millimeters. That's a significant amount of bone loss, especially if you didn't place your implant deep enough. So this, despite whether or not you place the implant supracrestal or subcrestal, we still may get this response because of lack of soft tissue. So the tissue is the issue. He also speaks about the depth of placement. So we place it a little bit too high versus placing it a little bit lower, and we can get different types of response. So this patient came to my office, and this is in 2011. This implant, I won't name names over here, was placed in 2010, this one in 2011. And it looks like one has some bone loss on it and one doesn't, right? If you look at this implant here, looks like it's losing bone. And over here, it lost its bone, but it's up to the first thread, that typical dieback. Was it placed deep enough? That could be argued for over where it's placed in terms of the CEJ of the adjacent tooth. But let's take a look at it on day of 2011. They look pretty good. This crown's looking very nice. All right, that corresponds to the posterior implant here. And this crown over here is looking very nice. Even with the lack of emergence profiling that we did on that, it still looks very nice. Let's see how it stands up over time. With the depth of the implant placement on this tooth, we get the same amount of bone loss, looks exactly the same, but look at the soft tissue and look what happens to it. So that component starts to change dramatically. And this is what we typically see. And this is at the point where we start to say, can I add some more porcelain? What can I do here? Do I have to change my abutment? Do I have to make a ridge lap type of design now to try to accommodate for this loss of soft tissue? So we'll talk about the microgap. We can debate that to death. You know, this implant has a microgap. That implant doesn't have a microgap. You know, I have less bacteria in this implant because of its conical connection, and then when it has this type of a connection, I get a little bit more. But when I have this butt joint connection, I get a ton of bacteria. And we can blame bacteria all we want, and we should, because we should be using implants that have a great seal. When you have a healing cap, if you guys use PRF or some type of poncho technique with collagen or any of that effect, and you put that into an implant, and you come back 3-4 months later and you unscrew it, and you still see that PRF or that collagen, it looks exactly the same as the day that you put in that healing cap, you know you have a solid implant that has a great connection, because it's preventing bacteria to come in and degrade that material. And I see that all the time with my implants. I go in and there's a piece of tissue, it doesn't even smell that bad at all. It hasn't really been exposed. It's almost as if it's been entombed inside the implant for the duration of the healing period. So when we unscrew it, we take our ISQ, we'll see that little piece there. But this micro gap, through many studies, including Linkevich, what they would check with that is all about the location of where you place your implants so that you don't have multiple micro gaps too close to each other. The closer the implants are to each other, the more that micro gap is going to stick around and start to invade to each other. So we want some distance between our implants, at least 3 millimeters. But if you look at these implants they tested, one they placed supracrestal, one they placed subcrestal. Different style design. And what they found, again, with the microgap placed at the bone level, experienced about 1.68 millimeters of bone loss. So we're getting that dieback again, getting that bone loss. Even without a microgap, with an implant like these that have or I should say a minimal microgap. So we're still getting that bone loss. Platform switching came out, and it's not that new. You would think like, oh, this has been around for decades already. It's not that long. The idea behind it being, well, first, before I get to the platform switching of the abutment, let's talk about the platform switching of an implant. These type of cutback designs have a bone platform switch. So the thread starts lower down, and we have our first shift, the bone shift, the osseous platform shift. Then, from the platform, going up towards the abutment, we have our second shift, and that's what we known as the platform switching or platform shifting. And we like to try to make these anatomically designed, to have an S-line type of a shape, to have more curvature to allow for soft tissue to fill in. And this study was actually from Lazara Porter in 2006 out in UCLA. And what they did was they mismatched the abutments. So for those of you who know how to use, let's say, the Zimmer system, that's a very popular system, the internal hex. They have the green, the purple, right, and the gold. Well, they just mismatched the green and the purple. They fit, and today we do this all the time. We call that platform switching. We put the green on the wider implants, and we make it a little smaller, or we do the opposite with the smaller ones, make it a little wider, the platform out and switch it out. So we can either accommodate or push away tissue. And they came up with that, and they found wonderful results. Why? Because when they made it smaller, soft tissue would invade around the area and keep it thicker. So we would now not violate that 2 millimeters of thickness minimum that you need around the soft tissue, in addition to the 2 millimeters from the bone. So this type of emergence profile that they discussed, they compared this one, and it had some okay success, but it wasn't enough of a shift. When we changed that design to give it more of a S-line type of a shape, that's when we start to see better peri-implant tissues. And it stands up the test of time. And this is from the article from Lazara. And you can see this type of an implant again, where it's narrower at the crest, right where the abutment, and it kind of looks like a little bit like a lollipop on a stick. We don't want it to be too small of a stick, but we want to have enough of abutment for support so we don't have fracture. These conically connected implants combined with that S-line type of a shape can give us some beautiful soft tissue. Again, in Linkiewicz's book, in the Zero Bone Loss Concept, and in many other articles and papers, they discuss that. The platform switch, along with elimination of the microgap, prevents a lot of that potential dieback or bone loss. But there's other things that's going on here, and as you read the book and you read the articles, you learn more about what they're actually doing to treat the bone. Looking at an SEM microscope and looking at, this is a Straumann implant, comparing the different types of connections and looking at where that eliminates to prevent a microgap, certainly can be very helpful in reducing the amount of bacteria that's going to stay in the area. Is it ever going to be zero? I'm not sure that we could ever say it's going to be zero. But right now it's at a level with conically connected implants that we don't have to be as concerned about the microgap as we used to be. So something else is causing dieback. But having these conical connected structures, having these abilities to block out bacteria from the internal surface and create a house for bacteria to live in, certainly does reduce it. And having a great connection that basically won't just dislodge. It's not like you can go over and bang the abutment to knock it loose. It's got to be stronger than that. It's got to be really wedged in, where you need to have some type of a removal tool to press against it to remove it. That's when you know you have a really solid, good connection. And there's, besides the implant we're using today, there are other companies here that have that. So look at them. I'm not trying to sell you an implant. I'm trying to sell you the concept of keeping this conical connection to reduce the chance of micro leakage. Again, using a soft tissue implant, that micro gap is now above the tissue or at the tissue. So you really don't have to be as concerned about the micro gap in tissue level implants. Looking again at the two designs, from having a more tapered, bone preserved, soft tissue preserved versus a straighter type of design, we preserve much more of that peri-implant bone and the peri-implant soft tissues, as opposed to the other implant on the other side of the screen. You just don't see that. And it should carry through from the healing phase. When you start to place your healing abutment, your transfer coping should be of the same type of design so you can capture appropriately. And then your final abutments or your temporary abutments should all be of the same, whether you're doing screw retained or cement retained. I prefer screw retained myself whenever possible. But we want to try to preserve that S-line type shape so that we can have more soft tissue in that area. So using aesthetically designed healing abutments as the ones that I'm showing you here are from the Megagen system, which we'll have today to use. You can see that S-line built in, especially as you go to the wider type of healing abutments. And the wider type of healing abutments will certainly help you in lots of ways that we'll discuss a little bit later on today. Oh, I'm sorry. Also, the variability of heights, not just widths, but having just from 4 to 10 millimeters wide, but also the available heights, going up to 7 millimeters tall. Why would I need 7 millimeters tall? Well, maybe I'm trying to do a soft tissue procedure and I need to bring my healing cap really, really tall to be able to tuck a soft tissue roll underneath to preserve that soft tissue or to thicken it out. So these biological S-line type design healing abutments can help us preserve help us develop that soft tissue at the start of surgery. If we're loading with a healing cap that same day, we can come back and see very nice results very, very quickly. We can use things like PRF or collagen to help us encourage that soft tissue or bio-exclude and come back and have great soft tissue. One little piece of advice, I'm scanning in my office. I use intraoral scanners. I have several of them. Beta test a bunch of these products as well. But if you are using analog impressions, this is what the transfer looks like. It's quite skinny here. It's not quite big. It's pretty skinny. So when we have a big sulcus like this, we really want to try to capture all of that sulcus. So real quickly, just take your transfer. I like to do open tray impressions. Buy the cheapest flowable composite you can find in the market. Flow it around, light cure it, so that while your assistant or while you are, whoever's doing your pouring for your impressions, painting your trays, you can keep that soft tissue stabilized so it doesn't slump. And then you can transfer to the laboratory what's in actuality going on in the mouth. They don't have to make a random guess as to where the soft tissue is going to be. So little cheap way, again, cheapest composite you could possibly find. 8 weeks post-op, this is what we do. We do a lot of ISQ readings, so we like to load early. We have a question?
You said you're scanning your cases, right?
So now, he's asking if I scan new cases, and all my cases are pretty much digital.
Okay, so are you comfortable catching
Oh, absolutely. What I love about intraoral scanning is as soon as I remove the healing abutment, I can start scanning immediately. So there's no delay. I'm not waiting for something to be poured. I'm not waiting for painting of a tray. I'm ready to roll immediately. Do I find a limitation in terms of depth? I think depending on the scanner. There's several different scanners. I can have a conversation with you. I don't want to make this all about intraoral scanning, but there are scanners that are better than others, certainly in terms of depth. But when we look at this 5 years later, it looks like we have a natural tooth there. It doesn't look like we have a false tooth there. And that's what we want to try to do. Our patients are not coming to us for implants. They're coming to us for teeth. So we want to try to recreate what they had as best as we can. And to do that, sometimes we have to implement little tricks like that for capturing soft tissue. So these double offsets can give us some really, really beautiful soft tissue. They can help us tremendously, especially in these all-on X cases that we may handle. So just not even using such wide healing caps, you can see such beautiful soft tissue forming around the healing abutments. Some other solutions, if your system doesn't have that, you can simply buy a customized system, like the VPI system. And for my good friend Johannes, he makes this system where you can work with pretty much any implant, and you can make your healing abutments customized in different shapes, using a silicone indexer, using a temporary cylinder, and flowing composite around it, and then you go and place it into the mouth. I recommend using a hex abutment or a tri-lobe or octagon, whatever you're using, but an engaging abutment, not a non-engaging, so it doesn't spin around and round as you put it in. That'll lock into place. But these can be really wonderful. We can use them. They can be tooth colored. This is one of the first cases I did. But you can see from here to here, we're trying to capture what would be, look like it, almost like a temporary crown. So we start to develop that soft tissue. And you can do this without these you can, systems. You can also just flow composite yourself, then add to it and customize it. This just makes it a little bit easier and faster. If you're in a high volume production office like mine, time is your most important factor. So if I'm going to spend a little money on a nice kit, but it's going to save me time in the chair, I choose to use those things. But that's not for everybody, and we understand that that may be the case. So you can always make it on your own. But again, the bone sets the tone. And everyone's talking about the tissue. Later today, we have a soft tissue course. And you'll see on lectures, maybe not this one because this is a full mouth reconstructive symposium, but in general, people are always talking about the tissue. You see so many people out there teaching, Otto Zur and Hertzler and so many people, Mary Steigman, teaching all these soft tissue courses all over the world. And people are traveling all over the world just to get it. You go to Howie Gluckman's course in South Africa. There's so many courses about soft tissue. But yet the bone technology has all stayed the same. What about the bone? We haven't really had a revolution in drilling with the exception of densifying bone, with osseodensification, with the Versa system. We haven't had any revolution in terms of how to prepare the bone for its future crowns.